Special greetings to you to this special session, a special mini symposium on advances in the management of invasive fungal infections in the compromised host. And I will be presenting on the role of novel azoles in the management of invasive aspergillosis in the compromised host. I would like to share with you my slides and proceed accordingly on this program. I would like to declare that I have no direct conflicts in the beginning of the symposium, and most of my conflicts are related to my invention on antimicrobial devices. I gave 2 talks, however, with Merck and Pfizer, who have products in my talk. I gave these 2 talks in 2020. This is the only conflict. I think the first slide highlights the basics, which is known to all of us. Invasive mold infections are a leading cause of morbidity and mortality resulting from invasive fungal infections, mainly in the stem cell transplant, and they're also an important source of morbidity and mortality in the solid organ transplant and hematologic malignancy. It is also well known to all of us that the patients at highest risk for acquiring these invasive mold infections in hematologic malignancy are the patients with neutropenia. And as you can see on this scoring system that is outlined here, the BO score shows that the prolonged neutropenia more than 10 days or previous mold infection or uncontrolled, that is malignancy such as relapsing and refractory leukemia, as well as lymphocytopenia with treatment agents such as fludarabine and others, would really put the patient at the highest risk for invasive mold infections, including aspergillosis. Aspergillosis remains the leading cause of invasive mold infections in this high-risk patient population, and the outcome is the best if treatment is started at an early stage, as reflected by a CT scan of the chest with a halo sign or with early nodules versus the crescent sign at a later stage. Now, this is a slide from a recent study demonstrating that also diagnostic-driven treatment, particularly if we zero on the lower part of voriconazole versus empiric treatment, which is just kind of giving the antifungal therapy based on signs and symptoms rather than on CT scans and galactomannan or other aspergillus assays, would really be as good or superior to antifungal and empiric antifungal therapy, and should be the route and the approach of treating these patients. Now, let me focus on the 3 anti-mold azole agents that have really made a big difference in the treatment of invasive fungal infections and mold infections, mainly the voriconazole, and more recently in prophylaxis posaconazole, and most recently is isoproconazole. The echinocandins are the main players in the primary treatment of candida, invasive candida infection, but not in they're not indicated as a single agent for the treatment of invasive mold infections. And I would like to go more into this as we go along. However, it's very important to note that the milestone work by Dr. Herbrecht and colleagues in their study almost 2 decades ago have clearly demonstrated that voriconazole is superior than amphotericin B in the treatment of invasive aspergillosis. Remember that in that study, most of the failures, or a good number of the failures with the amphotericin B, were related to toxicity to this drug. But however, there is preponderance of the data now coming across, and this is a study by Upton and colleagues from the Fred Hutch in transplant patients with invasive aspergillosis, showing that the voriconazole, when compared, survivorship was superior with voriconazole when compared to other agents, mainly the polyene antifungal agents. And this is a similar and even larger study on a large cohort and a longer period from our center at MD Anderson that we published again almost a decade ago that shows that the voriconazole, if used when compared voriconazole or posaconazole as a treatment of invasive mold infections, whether it's primary treatment or a salvage therapy, is superior to other agents, including the polyenes, amphotericin B-based regimen, as well as the echinocandins, in terms of full response, in terms of invasive aspergillosis-related mortality, or overall mortality within 12 weeks. The Achilles heel of voriconazole remains based on this data by Herbrecht and colleagues, although it's a safer drug than amphotericin B, certainly in terms of nephrotoxicity, but the Achilles heel is what you see on the far right, is mainly the hallucinations that you see with this agent, which has been a visual hallucinations, I mean, or the visual problems that could occur, visual intolerance or photopsia that you see with this agent in a good number, going up to 25 to 30% of the patients. However, it's also also important to know that from an efficacy point of view, that voriconazole has no activity against zygomycosis, and it could be also a risk factor, as by the study by my esteemed colleague, Dr. Contianis, where by multivariate analysis, voriconazole prophylaxis was a risk factor for breakthrough infection with mucormycosis, and hence this is the other Achilles heel of voriconazole to be noted. The other agent that I would like to highlight, which we have used prophylactically and which is similar in structure to itraconazole, is posaconazole. We're all familiar with these two studies of posaconazole versus fluconazole. First, by Ullman and colleagues in the prophylaxis for severe graft versus host disease, and the second study of posaconazole versus fluconazole or itraconazole as prophylaxis in leukemia or hematologic malignancy patients with prolonged neutropenia. In both studies, posaconazole was superior, and these studies were the ground for making posaconazole the agent of choice in the prophylaxis as a prophylactic agent, mainly for mold and other invasive fungi in high-risk patients with hematologic malignancy or stem cell transplant. However, we have been, with other colleagues, often conducting studies on the role, and this is a big question, of posaconazole as a treatment rather than prophylactic agent in invasive aspergillosis, for invasive aspergillosis. And here is one of the earlier studies, almost 13 years ago, with the use of this agent as a treatment, and comparing it to liposomal amphotericin, to actually amphotericin B, where it was really superior in terms of survival. This is another study when our patient population in hematologic malignancy, comparing posaconazole to high-dose lipid-based formulations, and in both situations, again, you find superiority of posaconazole. So posaconazole has a long track record of being superior and a good agent as far as a treatment of invasive aspergillosis. But this has not appeared in a prospective randomized multi-center study until recently by Martens and colleagues. Just to point also, we also presented good data on its role in treatment of invasive fusariosis, with a 48% response in the study we published in the Clinical Infectious Disease. But as far as zygomycosis, this agent has its limitations. In vitro, the numbers look good, But clinically, the study published by Greenberg and colleagues that we were part of in antimicrobial agents chemotherapy shows that really it was used, and the great optimism from the number of 79% response was used either in combination with the lipid-based amphotericin B or as a step-down therapy. And hence this number is not really what has been desired. But the most recent studies have shown that the oral tablets, unlike the oral solution, which has a problem in bioavailability and absorption, would really make this drug eligible for treatment, not only prophylaxis. And hence, based on this study that we also participated in and published 5 years ago, the mean actually levels would be almost around 2,000, where a good level would be above 1,000 for a treatment or even certainly prophylaxis with the oral tablets, which really makes the oral tablets, which are now becoming the standard of care, at a major advantage, and this is why they're widely used. The most recent study, which just appeared on February 6, 2021, and we participated in with Dr. Martens as leading this multi-center prospective randomized trial, shows that its efficacy is comparable to voriconazole in treatment of invasive aspergillosis, but the treatment-related adverse events are significantly lower in this patient population of high-risk patients. Now, the third agent with most recent data is the isoproconazole, a very interesting agent. It has a similar profile in terms of in vitro activity to voriconazole, but the Achilles heel of voriconazole, which is mucormycosis, has an advantage with better activity as far as this agent. And again, the most recent multi-center prospective randomized trial that appeared in the Lancet in 2016, and I served as a second co-lead author with Dr. Martens, shows that the results in terms of outcome were comparable to voriconazole at all levels, whether it's the overall mortality or the success or the clinical or mycological response. But there was the advantage of isoproconazole being a safer agent with significantly lower skin disorders and rashes, eye disorders, including the visual problems, and the hepatobiliary disorders. And all of this really points to the fact that this agent is a reasonable alternative. It also was shown to be as efficacious as amphotericin B in the treatment of mucormycosis, and hence got the approval of the FDA in the United States for this use. So I would like to show you at the end some real-life use in 200 patients with hematologic malignancy and suspected or proven invasive fungal infection. On the real-life use of the isoproconazole, actually what we found is almost 60%, 58% was used as salvage therapy, and mainly switch from other anti-mold agents, whether it's the amphotericin B-based regimen or the other azoles, such as mainly voriconazole. And you can see one of the reasons for switching were the adverse events or the complications with these other agents. The first four listed here mainly pertain to voriconazole, where patients on voriconazole had elevated LFTs with interaction with other agents, but again, they were able to tolerate much better isoproconazole, subtherapeutic posaconazole levels, where the problem is solved with ISA, which is highly bioavailable, and a prolonged QT interval, which is an extremely often ignored issue, whereas the isoproconazole does actually shorten the QT interval. And then the eye problems, which is the 3% of mainly of body visual hallucinations or other problems. Nephrotoxicity was a reason for switching from amphotericin B-based regimen to isavuconazole. Overall, even with the fact that it was used in salvage, it still had a 40%, mainly in salvage, 40% basically response rate, and the overall cause mortality at 6 weeks was quite reasonable and comparable to other agents, even when used as salvage. This is the final slide showing where we compared it at our center, voriconazole versus caspofungin, to highlight the point that it was significantly better, even by multivariate analysis. Voriconazole was better than caspofungin as a primary therapy of invasive aspergillosis. And this last slide sort of shows the recommendations by the guideline committee, Patterson colleagues, published 5 years ago on invasive aspergillosis. And I want to point to you the last kind of point here on these 4 points, that primary therapy with echinocandin is not recommended. And if you can, and where the combination of an anti-mold azole and echinocandin is to be considered is very select patients, possibly patients that require salvage therapy. But I would like to take you to the first point. As far as primary treatment, voriconazole is recommended, followed by ISA, or now with the study by Martins and colleagues that appeared in February 2021 in the Lancet, possibly posaconazole, if they have not been on these agents prophylactically. Now, alternative therapy would include liposomal amphotericin B to the anti-mold azoles. And I think these recommendations do still hold. I would like to finish by thanking you all for your attention and participation in this program. And if you have any questions to me regarding this program, I would like to ask you to send it to iraad@mdanderson.org, as you can see here on this screen. And we will be glad to respond to your questions. I would like to particularly thank Dr. Slavin and the leaders and the organizers of this excellent Immunocompromised Health Society conference for allowing us to participate in this program. Thank you again. Thank you.